The CANTOS study evaluated an antagonist of interleukin-1 beta, an anti-inflammatory agent, in patients who had high risk of coronary artery disease. And it was shown that an anti-inflammatory intervention can reduce the risk of coronary events without any changes in lipids. This trial really establishes, for the first time, the inflammatory hypothesis of coronary artery syndromes. And it's such an important study because there are so many different inflammatory pathways that can be targeted now. The question is, which one? And how will we go about proving each hypothesis? Because these clinical trials are very expensive, and the drugs that will result from these trials will be priced in a very rich manner. So we have both a wonderful opportunity, but we also have an enormous challenge because we can interfere with inflammation, but to get the answer, it will cost a great deal of money before, and it may cost a lot of money afterwards. Many people ask, when you have a drug that works for heart failure and a reduced ejection fraction, why does it not work for heart failure and the preserved ejection fraction? And the reason is these are two extremely different disorders. Heart failure with a reduced ejection fraction is a disorder of myocyte loss and injury, marked dilatation, neurohormonal activation. It is a disease where the neurohormonal activation drives the process and destroys additional heart cells. HFpEF, heart failure with a preserved ejection fraction, is a different disease. The heart is not markedly dilated. It's actually an inflammatory disorder. And it is a disease that we will need to treat with anti-inflammatory interventions. The heart is not stretched. The myocytes are not lost. They are not injured. There's fibrosis. There's a lack of distensibility. But the major problem is inflammation. So we will need two different kinds of drugs for HFrEF and for HFpEF.